Hello again, Dr. Andrews. Welcome back for another lecture at the MPMA 2021 Great Lakes Conference, a virtual affair this year. However, I'm kind of excited to see how this platform comes along. It's unfortunate we can't be all in person this year with our current public health crisis, but moving forward, maybe this will be an opportunity for us to do hybrid type educational experiences, both distance and live. So this lecture is on non-union prevention, a flashy, exciting topic, but very, very relevant because oftentimes, these are your biggest headaches. These are troublesome patients, and sometimes you can have delayed or non-healing fractures, delayed or non-healing arthrodesis sites, really through no fault of our own. So sometimes we just, end up with a string of bad luck for whatever reason, and we end up sometimes having to be more aggressive about these things to be able to enact healing. So our learning objectives, we want to discuss non-unions. We're also going to talk a little bit about, some statistical data and their real impact on public health. We're going to talk about risk factors. And we're also going to talk about surgical and non-surgical techniques and augmentation products for prevention of non-unions. So this presentation is kind of two parts. We talk about non-unions and their impact, how to mitigate risk factors, and then also we're going to talk about a little bit about biologics, bone grafting, bone graft substitutes, bone stimulation, and other techniques that we can use essentially to avoid the problem of delayed or non-union healing of bone. So me again, Dr. Andrews. I'm the program director for the McLaren-Macomb Hospital Residency Program, the evolution of the Kern Residency Program. We are a PMSR RRA program. We have 3 residents a year. I have offices in both Sterling Heights and Ortonville, so Macomb and Oakland counties. I'm tired of distance learning. I wish we could get together in person. And I have no conflicts of interest to declare for this lecture. I am a compensated endorser for a few different orthopedic and skin substitute vendors. However, I will not be demonstrating any products that I am endorsing in this lecture. This is a dramatization of our residents if they don't understand non-union prevention and mitigation. I have ways of being able to motivate residents to be able to get the job done, if you will. So non-unions are a giant pain. So we want to be able to minimize risk factors and be able to handle these types of things because, you can have perfectly healthy patients that will end up having a non-union, or you will have patients that have every risk factor in the world. They're overweight, they're a smoker, they're on dialysis, they're taking steroid medications, they're on chemotherapy medications for some reason, and sometimes they'll end up, having no problems healing whatsoever, and they'll heal within an appropriate time frame. But for the most part, risk stratification is very, very important. A lot of these non-union problems will follow along with chronic disease. So people with chronic disease processes that will enact a delay in healing timelines are notorious for causing problems. So diabetes is probably by far and away the biggest for a couple of different reasons, both through the accumulation of glycosylation end products, the AGE mechanism, which makes connective tissue structures a lot more brittle, and they have a lot higher content of sugar moieties. So a lot of the metabolic processes that are dependent upon charge-based proteins, you alter the structure and conformation of those proteins, and you really just have an impaired capacity to heal things. And then oftentimes with diabetes, you get other pro-inflammatory states that will cause upregulation of matrix metalloproteinases and other structures that really will limit or inhibit bony healing, both in fracture healing and for arthrodesis. So be proactive about these things. So risk stratify your patients if they have risk factors. If you have somebody who comes in with an ankle fracture and they're an active smoker, how hard do you have to beat them with a wiffle ball bat to get them to quit smoking or at least slow down on smoking? For them to heal their fracture site. And of course, the double-edged sword is when you put somebody in a cast, they sit on their butt for a couple of weeks, and that's all they do is they sit there and smoke. Those are usually our biggest problem patients, is the smokers. But then also anybody who's taking any kind of steroid medications, especially inhaled steroids. I think that's kind of a missed risk factors sometimes. Obviously, if you're taking 30 milligrams of prednisone per day because you have Crohn's disease, or you've got an MS flare or something like that, well then certainly that's going to be a major risk factor for healing. But even like inhaled steroids, like for asthma, COPD, oftentimes those can be a significant inhibitor of bone healing also. People who drink a lot of sodas, especially colas, will have a high phosphoric acid content associated with them, which is associated with metabolic bone leaching. Chemotherapy medications are notorious also because they disrupt metabolic pathways for cellular growth. Not only the target tissue, but they tend to do that everywhere. So we'll have patients that why isn't this healing? Why isn't this healing? Okay, well, you're taking Avastin for an ocular cancer. Okay, well you're not going to heal anything. You won't heal a paper cut in that scenario. So those are just a smattering of things that are going to delay us for healing. And then also be aware of your options. So know what additional techniques, what additional products or things that we can use to aid us and assist us with primary revision bone healing. If you have a non-union, do you necessarily have to do an open procedure to try to repair it, to do a structural bone graft? Or can you get away with things like corticotomy or drilling? Can you use injectable or flowable products in association with disruption of a non-union site? They don't necessarily have to be open procedures, but we've got some options, and I'll talk a little bit about those when I discuss some of the biologics. So how do we define a non-union? The textbook definition is essentially when you have 9 months that have elapsed since the fracture or arthrodesis index procedure with no healing progress for 3 months or greater. This is a long time. It's a long time for somebody to be dealing with having to wear a boot or a cast all the time. Really, we'll see obvious signs of a non-union typically prior to that. Our residents will know from studying for a board's perspective that there's some academic minutia associated with non-unions as well, such as the Cierney-Maeder classification. In practice, these things are largely useless. They really don't, they're good esoteric things to study for. That may show up in papers from time to time that we read, but for the most part, a non-union is a non-union, regardless of the cause, whether it's a hypertrophic non-union, atrophic non-union, either or, the end result is the same. You've got bone that's not healing or bone that's not consolidating in an appropriate manner. So I consider an appropriate definition of a non-union to be a fracture or osteotomy that has no potential to heal without further intervention. Does that necessarily mean you need 9 months after a fracture site? Absolutely not. I mean, that can be 3 months after a fracture in a lot of instances. So in order to appropriately define that, we have to look at osseous healing and how it progresses from hematoma through remodeling phase. So you fail to progress through the normal stages of healing. So hematoma, inflammation, proliferation, callus formation, or consolidation. So callus formation, keep in mind, is going to be necessary for secondary intention bone healing. And then cellular proliferation also can be a bit of a wild card in there. So if you've got any sort of metabolic or medical process that's going to limit inflammation and cellular healing, well, then you're going to have a significant impact on healing a bone. Delayed unions are basically a failure to consolidate within a normal time frame. So a delayed union is actually much more common, and I think a lot of delayed unions won't necessarily progress onto a non-union, particularly for like fifth metatarsal fractures. We'll have some obnoxious fifth met fractures that stick around for a couple weeks longer than they really should, but we really treat those really from a patient perspective. And I'll have people that will come in and, hey, should we take another x-ray? I'm still having some pain. Yeah, we certainly can, but is there anything that's going to change our management any? These are things that sometimes you just need to, give it time, so to speak. And then, of course, also a pseudoarthrosis, which is sometimes these can be painless, and sometimes we can actually use them to our advantage in certain instances, particularly in the context of Charcot. These are they typically have a synovial lining, so they're actually a false joint. They're fibrous, they're fibrocartilaginous. they will develop synovial tissue, so they can actually have inflammatory changes that occur within pseudoarthroses. And sometimes you'll have, for example, like a pseudoarthrosis of like a metatarsal neck fracture that will present itself in odd ways, and oftentimes these things will present with neuroma type pain, where they've got burning pain to the forefoot, but you're really looking at a pseudoarthrosis of a previous fracture site. So again, our biggest risk factors, by far and away, number one, smoking. Whatever you can do to beat some sense into people that you need to quit smoking if you want this fracture to heal within an appropriate time frame. As far as I'm concerned, take the gloves off. I've put people on Chantix before. I won't delve into Wellbutrin, which is sometimes still used for smoking cessation, but I'll refer them to their primary care doctor. Even in some instances, we'll do things like, trying to find them, quit smoking resources. I mean, there's hotlines that are available. There's plenty of websites that are available. Sometimes just pointing people in the right direction and kind of giving them a kick in the pants to get moving on smoking cessation will make a big difference. Oftentimes these people have longstanding peripheral arterial disease, or sometimes even like microvascular compromise. Even if they have palpable pulses in a smoker, that doesn't necessarily mean that you don't have some distal findings of delayed perfusion or poor capacity to heal. Vascular compromise is very important as well. So if you're not getting blood flow, to a site, well then, clearly you're not going to heal it. And that becomes important also in the context of things like avascular necrosis. But it's especially important for non-unions, especially for long bones. If you have disruption of the vascularity, oftentimes non-unions, and especially atrophic non-unions, are really just essentially due to a lack of blood flow. So sometimes pedicle grafts, like even like fibula strut grafts and things like that, may be necessary for like long bone defects. Diabetes as well, which we discussed, the AGE theory. So when you have a high concentration of charged molecules like glucose or sucrose within, or even fructose within nerves, which can be a problem, you have biologic activity, not only from a osmotic gradient effect, but also, if you alter the charge of some and conformation of some proteins by adding sugar moieties to it, well, then you're going to, really restrict appropriate biologic function. You're going to disrupt metabolism. So diabetes really slows you down. It slows down wound healing just as much as it does anything that's a vascular-derived healing process, such as healing of bone. Inflammation and inflammatory disease processes, which is a very wide swath of disease processes that will limit bone healing. Rheumatoid arthritis is a common one, psoriatic arthritis, lupus, other like inflammatory neurologic problems like CIDP, or things like multiple sclerosis, spinal cord dysraphisms, things that are inflammatory in origin that are generalized. Even people that have inflammatory bowel disease like Crohn's or ulcerative colitis oftentimes will have a chronic low-grade inflammation that goes on throughout the body, which causes some things like transient drops in pH in local environments and things like that can really limit bone healing as well. Steroid class medications will clearly limit bone healing as well, just because you're limiting phospholipase A2 and limiting any kind of robust inflammatory response. So you need inflammation to be able to heal bone or heal wounds or heal just about anything, but you need to kind of use it in a controlled manner. Inadequate fixation is a major thing too, especially that I see. We do a lot of revision work in our practice, and I see a lot of things that were inadequately fixated, that allowed for micromotion, where implants that were used are too small, or you not using locking plates and screws when it was indicated, things like that. Then obviously the big one is like if you have a lot of motion at a fracture site, or you're not compressing a fracture site or osteotomy site. Infection is a big one too, of course. That's going to disrupt everything. And of course, patient compliance. You can have the best looking fixation on the table. If your patient walks all over it, it looks terrible. And then of course you have to submit those cases for your ABFAS certification too, and try to plead with the board examiners that you indeed did the right thing. However, the patient was responsible for their own poor outcomes. Local risk factors, things like open fractures, oftentimes are associated with poor bone healing. There is a direct correlation between severity of a Gustillo and Anderson open fracture injury. That correlates with risk of non-union. I could not find that paper for this, but I know it was something that I reviewed within the past few years. High energy injuries like high energy trauma, polytrauma, several fractures, anything where you're worried about degloving or loss of vascularity to the bone. Segmental bone loss, especially if you have periosteal stripping, that's a major risk factor for non-union. And then, of course, like we discussed before, infection and poor surgical technique. So phases of bone healing, just for review: hematoma, fibrocartilaginous, bony callus, and then bone remodeling. So bone needs to progress through the 4 stages of healing in order for us to heal bone appropriately. And of course, we can sometimes get away from bony callus healing if we have rigid apposition of bone with an internal fixation construct like this. So this kind of shows the difference between primary and secondary bone healing just by use of an internal fixation construct where you have direct formation of new haversion canals across a fracture or arthrodesis site. Whereas if you undergo callus healing with secondary bone healing, the bony callus largely acts as a splinting mechanism, which does allow for haversion remodeling. However, it's a much slower process, and it's much less organized than primary bone healing. So primary bone healing requires compression. If you have compression across a fusion or fracture site, you get stabilization. It's rigid. You produce friction. You're going to develop haversion canals and haversion remodeling through osteoblast activation and osteoclasis without forming a callus. You basically skip an entire step if you're rigidly opposed. Secondary bone healing is a bit of a different story. The fragments are stable, but micromotion is available and oftentimes will lead to callus formation, and you get a natural upregulation of chemokines as a response to this. The endosteum of bone, especially long bones, the femur and the tibia, have a lot of endosteal mesenchymal stem cells associated with it. So oftentimes when you disrupt the endosteal bone, that's where most of stem cell activation peripherally is going to come from. Stability of a construct is also extremely important. If you have absolute stability, that means there's no movement whatsoever. You get good compression, you have good rigid constructs, but this is not always necessarily very advantageous to us. Sometimes we want relative stability, where you still allow for a little bit of micromotion, where you can rely on things like the piezoelectric effect or Vassell's principle, if you will, to be able to to bridge fracture sites, to bridge osteotomy sites, and to hold things together. So why is this important? Upwards of 10% of fractures in the U.S. every year are associated with a delayed or impaired healing, usually due to the aforementioned risk factors that we already discussed. But like I said, oftentimes it can be related to poor surgical technique or really through no fault of the patients. Sometimes we're the problem, but oftentimes it's patient-specific risk factors for illness that really give us a lot of problems with healing. So let's mitigate this as best as we can. I had a patient who had a major procedure of the rear foot, and she was so excited that she borrowed her deceased husband's scooter, and she rigged a bungee cord so that way she could suspend her legs, so that way she could kind of cruise around the neighborhood. And she showed me how proud she was of this, and of course she sends me this picture, and she's got a cigarette hanging out of her mouth. So of course I let her have it about that a little bit, but the one thing I want everyone to realize about fixation is use rigid, robust fixation. Use in excess of what you think you need. So use strong screws. If it's anything in the forefoot, rarely consider using anything smaller than like 3/0 screws. Use a very robust fixation construct. These are weight-bearing joints. As a population, we're pretty fat, so you want to make these things stupid-proof and strong. But know the limits of your fixation also. Know what you can and can't get away with. Sometimes with a fixation construct, you can do like an all-locked plating, for example, but oftentimes it's a very, very rigid construct and doesn't allow for any micromotion, which is not allowing for an increase in friction between bony fragments. Augmentation products and things like biologics, be proactive about use of these products. By all means, if you have somebody that has risk factors, use a calcium ceramic as a substitute. Use some demineralized bone matrix. Use PRP. Use bone marrow aspirate, or some of these synthetic products. So it's well indicated if you've got a patient with risk factors for healing. What I don't want is for anybody to be brought up in court and say, hey doctor, this patient is a smoker and they have diabetes. Isn't the use of augmentation products for bone healing appropriate in that case? That's kind of a tough thing to defend. And then also, as best as we can, minimize risk factors. So risk stratify your patients. Determine, are there things that we can do from medical management standpoint to be able to increase the likelihood they're going to heal? Are they on a biologic medication that they can take a reprieve from? Are they taking medications for rheumatoid arthritis or lupus, for example, that we can take them off of for 4 weeks to in effort to boost the capacity to heal, things of that nature. I do a lot of revisional type procedures. These are procedures that were done by other surgeons that have shown up in our office. All these fixation constructs, like you look at them, and in retrospect, I kind of shake my head. The one on the right, not so much, because that's a bone graft that kind of resorbed. But, make sure your fixation constructs are appropriate. This one on the left here, like I said, even though you have a little bit of compression across there, that is not in any way rotationally or axially stable. And then this one in the center, I'm not quite sure what's going on with that. That was clearly, malreduced, if you will. I'm going to pay brief lip service to bone stimulation. You could easily write an entire lecture on bone stimulation and the science behind it. These are products that are either electromagnetic based, that are going to induce piezoelectric activity within the bone, or low intensity pulse ultrasound, like the device in the middle, which is, there's advantages and disadvantages to each. The low intensity pulsed ultrasound units tend to be my go-to for an external stimulator unit, just because it's ease of use of the patient. They can use it for 20 minutes a day. You literally push the button and it goes, and it runs a cycle. And as long as your patients are appropriately educated on it, it's pretty easy to use. You can use implantable devices such as the one on the left here, and you can do pulsed versus continuous, and data supports use in a lot of these. The low intensity pulsed ultrasound unit does have an indication for fresh fractures, whereas oftentimes for insurance coverage for some of the other electromagnetic type bone stimulators, oftentimes you need to reach that threshold where you have greater than 3 months of non-healing in order to qualify as a non-union. So gold standard for any kind of non-union for grafting is always going to be autogenous iliac crest bone graft. I purposely put gold standard in gold here, however it doesn't come out very well in this PowerPoint font. This is going to be the gold standard. This is going to be bone that has a high density and high quality of mesenchymal stem cells associated with it. Good cancellous, well-vascularized bone. The problem with this is that donor site pain and donor site morbidity is a significant problem. And then in a lot of cases, Jim DeOrio and his colleagues, the Ortho Carolina group, they did a study that showed use of iliac crest bone graft, the harvest site, the pain from that bone harvest actually eclipsed the pain from the index site in over a quarter of the patients. So this is, it's a separate orthopedic procedure, not without significant risk. However, use of autogenous bone is the gold standard. So of course, just a brief review of some of the principles of orthobiologics. You want to have something that's osteoconductive, that's going to allow for ingrowth of fibroblasts, ingrowth of collagen, that's going to have a porous structure that's going to simulate that of bone. You want something that's osteoinduction. It's going to induce bone to heal. This is oftentimes the organic composition of bone, things like demineralized bone matrix, things like platelet gel concentrates, platelet-derived growth factor, things like that, even things like peripheral marrow and peripheral stem cell draws. These are things that are going to be osteoinductive and going to induce bone to grow. Ceramic bone substitutes, there's several on the market: calcium sulfate, calcium phosphate. These are good things for backfilling of screws. They're good for filling defects, especially like marrow lesions of flat bones, like the talus will use, like for a subchondroplasty technique. But these are things that are not necessarily used as a primary non-union prevention device, but they can be used to kind of shore up bone, especially if if you have any cystic changes or things like that that can be filled with some of these ceramic bone substitutes. Calcium sulfate is an oldie but a goodie. It's basically medical grade plaster of Paris. You basically make it by cooking gypsum, and it's pretty strong, but it's pretty brittle. And the problem is it elutes very quickly. It resorbs very fast. It's great for things like mixing antibiotic beads, but for use and filling of primary bone defects, I don't really use it much. It's nice because it's you know, it's a shelf stable product, and it doesn't heat up like PMMA cement does if you're trying to mix antibiotics with it. Calcium sulfate comes in a couple different formulations. Oftentimes it's mixed into beads, of course. And then I have a couple studies that basically just show you know, good results with calcium sulfate pellets alone or in combo with demineralized bone matrix in patients that have like long bone defects. So these are things that are good for, you know, not only for non-union repair but also for segmental bone loss. Calcium phosphate is a product that I use frequently just because it has a much slower absorption profile, and it doesn't elute as much, and it doesn't elicit as much of a biologic reaction, mostly just because it doesn't hydrolyze nearly as quickly as calcium sulfate. These are flowable or injectable. You can get them in a cement form. You can get them in an injectable form. Again, you can mix it with antibiotics. It's a non-exothermic reaction. These are oftentimes complex with iohexal, which is a dye that will allow you to see the flowing, so to speak, like under a C-arm. It's very, very strong, but it's brittle. So it's got excellent tensile strength, but it's, you know, somewhat brittle. Doesn't stand up to shear forces too well, and it takes a much longer to resorb. So calcium phosphate is kind of my material of choice as far as a calcium ceramic for things like filling of voids, especially things like if you have like a lateral wall blowout calcaneal fracture, you can backfill it with a medication like the Hydroset. I like this picture on the right here where it looks like they're filling a skull defect. That's kind of a dramatization of what I feel like I'm doing with residents sometimes. Again, some pretty good data. I'm sorry, this font's not the greatest here. Meta-analysis of randomized controlled trials that showed reduced risk of loss of reduction in calcaneal fractures, and also a case series of depression-type calcaneal fractures where they were injecting calcium phosphate with pretty good results. Beta-tricalcium phosphate is kind of the evolution of that. You basically, from cooking coralline hydroxyapatite, similar compressive and tensile strengths. This is, as far as calcium ceramics go, this is probably one of the best things that's out there. Has pretty good resorption characteristics as well, and structure-wise, it's the most comparable to mammalian bone. Beta-tricalcium phosphate is also widely available. It's an excellent bone graft substitute. And then there's also things that are essentially a mix. These are usually proprietary by some of the manufacturers that are composites of calcium ceramics. Other things that are biologic in origin, BMPs, recombinant human platelet-derived growth factor, PRP, mesenchymal stem cells, and DBM. I'm going to glance through some of these pretty briefly because I've only got a couple minutes left here. BMPs, there's several that are available. These are used mostly for spine procedures. They're used in some dental procedures, jaw and facial reconstruction. Their biggest drawback is that they will cause heterotopic bone formation. So if you inject this stuff into soft tissue, you're going to start growing bone within the soft tissue. Good results in healing complications in patients with segmental bone defects or that have risk factors for healing complications. So I both of those products. Recombinant human platelet-derived growth factor. So PDGF is a component of a product that is FDA approved for hindfoot and ankle arthrodesis, and that's Augment. Again, I have no financial ties to Augment or its current owner, Right Medical, which is recently bought by Stryker. This is PDGF that's mixed with beta-tricalcium phosphate. This stuff is liquid gold for fusions of the rear foot. So if you've got a tough subtalar fusion, you got a tough ankle fusion, Augment is a fabulous product. Comes in flowable, comes in granules as well. A lot of ongoing research regarding Augment, but their come-to-market studies were very impressive. And even though I know that's kind of cherry-picked industry-sponsored data, we've got good results with it. PRP has kind of fallen out of favor a little bit. It used to be big with ortho groups probably 10, 15 years ago, and everybody bought a PRP centrifuge. There's good evidence that shows PRP has excellent augmentation capacity for bone. However, its soft tissue characteristics are kind of limited. DBM as well, organic and inorganic components of DBM. Essentially, this is a good scaffolding for additional bone growth. This is both osteoconductive and osteoinductive. It's very cheap and it's very easy to procure. So essentially, you just take the mineral component out of bone and you're left with the organic component, which includes mostly type 1 collagen and a lot of structural proteins. Comes in a couple different forms. Easy to inject, easy to mold into different different things as well. Stem cell grafts, this is these are very expensive products. These are multipotent stem cells. They don't really elicit any kind of significant host response. They are very expensive products. These are a couple $1,000s each, but we do use them for high-risk fusions with very good results. The Stryker Bio4 product used to be an Osiris product, which Stryker purchased a couple years ago. Is probably our procedure of choice. These are big in the world of spine, where non-unions can be catastrophic, but we have very good success using these products as well. And also just threw in there for completeness the use of recombinant human parathyroid hormone for non-union repair as well, and there's some ongoing trials with that. So there's a lot of things that are available out there for non-union prevention, non-union treatment. Evidence supports their use, both in acute injury and reconstructive procedures, particularly in patients who have a lot of risk factors for healing complications. A lot of the studies that are out there are not randomized. They're largely case series. There's not a lot of good high-level evidence or a lot of high-level data for a lot of these products, but evidence definitely supports their use. So if you've got people that have risk factors for for healing, you're well within your rights to consider use of augmentation products, whether it's a living cell therapy or whether it's just like a structural graft that you're using. And then of course, throw the kitchen sink at some of these, especially your real high-risk patients. Bone healing is a multifactorial process, so you can use a bone stimulator, you can use bone marrow aspirate, you can use shockwave therapy. There's a number of things that you can do in combination with each other, really, to be able to move the healing process along. And then sometimes also revision surgical procedures are worthwhile. This is just a recent example of a patient I had that had a non-union arthrodesis of the first metatarsal phalangeal joint and had a previous hardware removal. She's walking around in pain all the time, where she's got a lot of jamming, of that dorsal joint, and it's like gapped wide open, and she does a little bit of motion there. So as opposed to going back and fusing it, and somebody who is smoking probably greater than a pack a day, I proposed a different option to her, and that was really just an oldie but a goodie, a Swanson implant. I still do a couple of these a year. This is a fabulous procedure. It's not a joint replacement, it's an interpositional arthroplasty, but people do very, very well with Swansons, so long as you don't use an undersized one. I've done a couple of revision Swansons where the original implant that was put in was probably too small for the patients, so I generally say err on the side of using a larger Swanson implant, just in this example, of course. Again, these lectures will be uploaded to YouTube, as well as they'll be available at the MPMA 2021 Great Lakes Conference. Any questions, issues, complaints? I don't listen to praise, so mostly just questions or complaints. You can certainly email me if you want to. I'm very available. Thank you again to the Michigan Podiatric Medical Association, to Dr. Hussein, for all of his efforts putting this together, and of course the MPMA staff. So this is the third of 4 lectures, so we'll see you in a little while.